Discussing postpartum hemorrhage. Can you hear me, Rachel? You give me a thumbs up? Yeah. Um, Discussing our series on postpartum hemorrhage. This week we're going to be talking about etiologies and management associated with specific etiologies. The next slide. So obviously you can't treat it unless you have a good idea of what's causing the hemorrhage. We try to maintain hemodynamic stability, whether it be with fluids, giving blood, treat the underlying cause. The next slide will go over the different etiologies, and I think it's important to really understand the different types of hemorrhage. Primary postpartum hemorrhage is what we talk about the most, and that is bleeding within the first 24 hours of delivery. Secondary hemorrhage is that bleeding that occurs, some people say 24 hours, others say 48 hours and beyond, up to 12 weeks after delivery, and is a totally different set of etiologies. With the concerns for primary postpartum hemorrhage, uterine atony is definitely at the top of the list. That accounts for 70 to 80% of the cases that we deal with every day. Then to assess for maternal injury lacerations, whether it be cervical or vaginal and perineal lacerations. Can't forget retained placenta as you go through your process of trying to rule out what the causes of the excessive bleeding are. Abnormally adherent placenta, typically there's a clue to that when you can't get the placenta out easily and it may come out in pieces. And then defects in coagulation, whether it be DIC or even other inherited coagulation problems. We always put uterine inversion in the grouping. It's a much less common. I'll be curious to hear from providers that are on the call how many times they've seen uterine inversion. I've seen it 4 or 5 times. And it typically is a pretty easy thing to deal with if you act quickly, and it can really diminish blood loss. I like to look at it, the 4 T's: tone, tissue, trauma, and thrombin, just as you go through the issues, but most often you fall into the tone category. Let's go to the next slide. So assess for pelvic injury, and that's easier said than done. I mean, all of us have been there and they're bleeding excessively. It's difficult to see cervical lacerations or vaginal lacerations, particularly in an obese woman, and you're trying to look in the top of the vagina, don't have good lighting, don't have a lot of good help to show you. It's not simple, but is absolutely essential. What I tell people to do all the time is put pressure, put a lap sponge in there, try to dry it up and look as quickly as you can. I like to sweep the uterus with my hand to make sure that I don't have any retained products, or see if I feel anything that is not normal. Ultrasound can be extremely helpful in these circumstances, particularly when you think that there might be some retained placenta there. And if you're not sure if there's a uterine rupture, a lot of times you will see significant amounts of fluid within the abdominal cavity. And at the same time, checking coagulation labs. I always try to tell you guys that have participated on the simulation coach with me, you know that I like to draw a red top tube and watch it for clotting. It should clot within 5 to 8 minutes, and if not, you need to worry that there could be a coagulation defect. Next slide. So management of atony really is based around uterotonics, which is our back pocket medications as obstetricians. We use them a lot. We use them routinely, and routine use of uterotonics after delivery has really diminished the risk of postpartum hemorrhage, but it can still happen. One thing that's not in this list that I think is important to be a part of all of our practice, and that is uterine massage after delivery, transabdominal. But if you have uterine atony, to do the bimanual uterine massage with hand and vagina and hand on the abdomen to rub that uterus between your two hands can make a tremendous difference. We'll talk a little bit about tamponade and other surgical interventions as well as embolization. I won't say a lot about hysterectomy except to say that if you remember from our last conversation, our incidence of postpartum hemorrhage in the United States has gone up over the last 20 years, while mortality associated with postpartum hemorrhage has decreased. And the reason that our mortality has decreased is that we are much more quick to give blood and we are much more quick to do a hysterectomy than we have been in the past. And I think that that has definitely been life-saving in these situations. Next slide. So the oxytocics that are the medications here, oxytocin is the first one. That's the one we give to almost everyone, either IM if they don't have an IV or IV medication and a continuous infusion. Works very quickly. Once you start Pitocin, you can start to see the effect within 1 to 2 minutes of administration. Can be given intrauterine, but it's really not been shown to be any better or more efficient than just IV or intramuscular to mom. The ergots, methergin is our mainstay, 0.2 IM. Do not give it IV. I've had young, inexperienced anesthesiologists that have given it IV. It can cause a hypertensive crisis that is impossible to overcome. Do not use it with hypertension or preeclampsia. I mean, there's certainly times that you can give it to a patient with a history of hypertension. If they're hypotensive and you don't have any other options, certainly use it. It also works very quickly. Within 2 minutes, you can see an effect, and you can give it more often than every 2 hours, even though that's what the pharmacologists say to do. When you're in the throes of battle, you can increase the frequency. Hemabate, a great medication. It's really expensive, so it's one of the reasons we don't use it. It also causes pretty significant diarrhea as a side effect, but it works well intramuscularly. I did a study some years ago looking at intramyometrial versus IM, and it really is just as good intramuscularly to mom. It works likewise very quickly, and you can give doses every 15 to 90 minutes, up to 8 doses maximum. Misoprost really does not work for acute hemorrhage, but it helps decrease the recurrence because it doesn't take effect until usually 30 minutes after administration. But to give it sublingually, but primarily rectally, is the best way to give it. Now, it's not on this list, and this list came from the ACOG practice bulletin, but I think it's very important to remember to consider TXA in these patients. TXA is not to help increase contractility, but it's to help decrease the hemorrhage, and it has been shown to improve outcomes with postpartum hemorrhage. It decreases fibrinolysis. You give a gram and you can repeat it in 30 minutes. And I'm a big advocate. It's very inexpensive, and it should be on your labor and delivery unit and have the ability to utilize that. Next slide. So the tamponade techniques, I'm going to show you some pictures in a few minutes of these. The Bakri balloon has been around for a while and is actually what we still use. I think in our last discussion, we talked more about the Ebb tamponade system. I've seen it in YouTube videos and had it demonstrated, but we haven't used it, and Dr. Johnson may want to speak to that a little bit later as we go through it. The Foley catheter balloons are very useful in small uteri. Let's say you get into bleeding after you've done a D&C or an early second trimester loss or termination. Using a 60 cc balloon to tamponade intrauterine bleeding can be tremendously helpful, where the Bakri and the Ebb are just too large to go into the uterus. And I am old school. I still believe that uterine packing has a place, in management of these patients. Let's just say, I mean, you might not have the opportunity to have one of the other balloons, and I have typically used regular lap sponges and tied the tails together, and I use up to 5 on a term uterus and pack it tightly, and it works very, very well. I generally soak it either in Hibiclens or betadine before I pack it, and then remove it 48 hours or 24 hours later, but it works very well. Next slide. So this is just to reiterate the massage. I just can't say how important I think that this is in the management of uterine atony. Give them the uterotonics, and then the bimanual massage can be very, very life-saving. Next slide. So the Bakri balloon, you can see here, I'm sure most people have at least seen it in a package. We do show you this when we come out on our sim coach. The next slide demonstrates, next slide, where it needs to be. So to place it directly in the uterus and all the way in the uterine fundus, and infuse with up to 500 cc's of saline, increases the tamponade and decreases the hemorrhage. It increases the effectiveness of this. If you blow it up in the lower segment, it ekes out of that lower segment. If somebody's had a vaginal delivery, this is probably the biggest drawback to the Bakri, in my opinion, is that if they have been complete and delivered, that uterus, as it starts to contract down, will frequently displace the Bakri into the upper vagina. It can make it difficult. So in that case, and because we still use the Bakri, I advocate packing the vagina with a lap sponge to try to maintain proper placement of that Bakri as the patient starts to respond to all the uterotonics and interventions that we do. Next slide. I think this is the Ebb Glenveigh device, so that it has an intrauterine balloon that you can directly place it or indirectly place it, inflate that balloon up to 500 milliliters, and then it has a vaginal balloon that you can inflate as much as 300 cc's, but helps maintain the proper position. And that's probably the biggest benefit of this balloon tamponade system over the Bakri. And it really seems like it would be a great device to use. I'll be curious to see what others have thought as they have used it in their practices. Next slide. So the surgical interventions require you to be in the belly. So it requires a laparotomy. Hypogastric artery ligation, I've put totally on the side table. I think it's been shown to not be very effective in managing postpartum hemorrhage. Plus, it's a difficult technical procedure if you don't operate in the retroperitoneal space very often, which I don't. The O'Leary stitch and the uterovarian stitch have been helpful. Next slide. It basically, you lasso the uterine artery at the lower segment, just lateral to the uterine incision where you've made it, and the uterovarian artery ligation in the upper, right through the mesosalpinx. These do not stop the hemorrhage. So what these sutures do is decrease the pulse pressure, decrease blood flow, and can slow the hemorrhage to allow your uterotonics to take effect, but they do not resolve the issue. Okay, they work great, but and I certainly have used them, but this is the suture that I typically use, and that's the B. Lynch compression suture. There are a lot of different descriptions of this type of compression suture. This is the one I prefer. I think it's the simplest. Suture in below the incision and out just above it. You do the suspender wrap around the fundus of the uterus, and then place a suture across the back of the uterus just above the uterosacral ligament. Bring the other stitch across the fundus and reverse in above the incision, out below. And then the key to this working is you have to have your assistant crumple that uterus down while you cinch the knot down. And if you get a good compression suture placed, that uterus looks like a rump roast. It's just all crumpled down, and it works very well. And this is the one that I use if I'm already in the belly doing a C-section and I have significant uterine atony. I will place this a lot more quickly than a lot of my partners might. I don't always give the uterotonics as much time as I've seen some of the other folks, but I will place this suture and have had great success with it. Next slide. So embolization, I'm not as big a fan of. I think that it is reserved for those who have more slow, persistent bleeding. We use it a lot more if we have somebody that has intra-abdominal bleeding after a surgery. The descriptions have been very good with success rates as high as 80% with embolization, even with consistent or continued postpartum hemorrhage, even from uterine atony. Typically, in the cases that I see, we would not have time to use embolization unless it is a more slow and persistent bleed. It does help retain fertility, and again, in certain people's hands, it's been described as very effective. Next slide. So the last one to mention is uterine inversion, and for those who have seen it, I think the key is quick response. It's interesting, but it's not as easy to identify as some might think. I guess those of us who've seen it quite a few times recognize it more easily, but I've gotten more calls to the operating room for a prolapsed fibroid and discover that it's a uterine inversion than a suspected uterine inversion. But I used to give terbutaline in these cases. At one time we'd give ridodrine. And what I found to work the best is either IV nitroglycerin or nitrous oxide. It absolutely relaxes that uterus and allows you to put your hand in, cup that inverted uterus, and then just place it back in its normal position. I've only had to operate on a patient with uterine inversion one time to relieve the inversion. So that's a pretty uncommon event. These patients can bleed tremendously, but once you get the inversion done, then uterotonics to get that uterus to contract down, I've never seen it recur. So once I've gotten it back in, it has stayed reduced. So I'll be curious to see if anybody else has other comments about that. I think that's the last. I think we've actually changed our order of our discussions. I think our next discussion will be abnormal placentation, and then followed in 4 weeks by estimated blood loss and management with blood transfusion. So I'm going to stop there and see if anyone has any questions or comments about other interventions that you have found helpful in patients with significant postpartum bleeding.
Thank you, Dr. Campbell. And before we open for questions, just a friendly reminder, if you would like to request a copy of today's didactic video presentation, so please reach out to me. And Dr. Campbell, is this what you were referring to as our next topic? I want to, if it's not correct, we can disregard that. I think next time we're going to talk about a morbidly adherent placenta, okay.
But we'll get that straight on the website.
Okay. And I will go ahead and close out and turn it over to Dr. Johnson and Dr. Campbell for questions with the audience.